What I see in a lot of cases when I'm looking at these C-SNP plans around the country is lower co-payments at specialists, lower co-payments at the hospital, maybe better give back options for those plans. In a lot of cases, like for instance, diabetics, you're going to see a lower tier level or better coverage for things like insulin on these plans. So it does give your clients better benefits to be on those plans. Not only does it give your clients better benefits, but it also gives the carriers more money and higher margins. You're making the carriers happy and you're making the clients happy by getting them on the right plan. Hey guys, Curt Graham here from Elite Insurance Partners. Wanted to do another industry update, but today I'm not talking about any rule change or any law change or commission cuts or anything along those lines. What I'm actually talking about is something that I noticed when the Medicare Advantage first looks were released right before annual enrollment period. As I went through each one of them from all the big top carriers, I noticed that they had a bigger emphasis this year on chronic condition special needs plans. Yes, they were talking about all their normal plans and they were talking about dual eligibles, but it just seemed like there was more of an emphasis on chronic condition plans. And it made me start thinking and wondering why that is. And so I went looking around and I actually found an article from the Kaiser Family Foundation here. And it's a closer look at the growing role of special needs plans in Medicare Advantage. It came out September 25th of this year. If we come on down here, I've highlighted a couple things. Between 2024 and 2025, growth in special needs plans comprised nearly half or 48% of the total increase in Medicare Advantage enrollment. Absolutely huge amount of growth coming from this one smaller portion of the Medicare Advantage industry. If we keep coming down here to the key takeaways, through 2024, growth in special needs plans was driven by an increase in enrollment in dual special needs plans, which grew from 2.2 million enrollees in 2018 to 5.8 million enrollees in 2024, 90% of special needs enrollment growth. But looking at last year, C-SNPs comprised 75% of total special needs plan growth during 2024 and 2025, in contrast to prior years, which was mainly dual eligible. C-SNPs enrollment increased by 476,000, D-SNP by only 159,000. So we had a big shift from the C-SNPs or from D-SNPs over to C-SNPs. Now, if we come down here, why do carriers like these plans so much? Well, it's like everything else, follow the money. Special needs plans receive higher per capita payment under Medicare Advantage payment system on average because enrollees have higher expected spending due to their higher healthcare needs. Yes, this is definitely true. If somebody has a chronic condition that costs a lot of, that causes them to go to the doctor more, has worse health conditions, maybe they're in and out of the hospital, it's going to cost more to take care of them. But they also state here that MedPAC found in 2022, the average margins on D-SNPs was 7.5%, on C-SNPs 7.4%, whereas the rest of Medicare Advantage was 3.6%, double the margin. So the carriers are actually making more money, but this also still gives them higher payments, which leaves more resources for supplemental benefits. All of the food cards and all the extra benefits that we see advertised all the time, that's what they're talking about. If we come down here, this great graph right here shows the growth over time, and it really illustrates where the growth is coming on the chronic condition plans, almost doubling in that time period. And looking at the regular, dual eligibles, it's 5.8 to 6 million, kind of a flattening growth line. Well, as we come down, why is that? Well, beginning in 2025, fully integrated dual eligible or FIDEs, special needs plan, and highly integrated dual eligibles or HIDEs have new enrollment benefits and coordination. So basically what ended up happening is they made a new rule where the carriers needed to be more integrated. The additional requirements are intended to promote better integration between Medicare and Medicaid for enrollees to make D-SNPs less attractive to private insurers. Essentially, if an insurer wants to offer a dual eligible plan, they need to be on a contract for both Medicare and Medicaid in the state. Wasn't really the case before. So that does make it harder for some of the smaller carriers to do that. If we keep on coming down here, we can see how this affected everything. As we come up, it was just absolutely huge growth on the dual side. And then when that new rule comes into place in 2025, it drops through the floor. Okay, while chronic condition is still going up. Now, I mentioned before, the carriers make more money on these plans. So I looked up the Medicare Trustees Report. This comes out of CMS. I'll link to it in the description. We don't have to read through this whole thing. It's 267 pages, but I did, and I found some pretty interesting tables. This is a table that shows you the average cost of a Medicare beneficiary on Medicare Part A, B, and D. So on original Medicare, in 2026, that total cost is $19,868. If we come to this next chart, this is for all of our managed care plans or Medicare Advantage plans, HMO, PPOs, as well as private fee-for-service and special needs. If we look down here at 2026, the regular HMO, we're looking at $15,265. On the PPO side, about $14,200, depending on if it's regional or local PPO. Private fee-for-service, we're looking at $17,000. And then on the special needs plans, $23,000. Significantly more money for the plan itself. And what does that mean? It does mean more benefits. It does mean that we are dealing with a sicker population, which are going to cost more money because they're typically going to be going to the doctors and hospitals more. But that extra benefit, extra money, does mean that they can offer better benefits. So what I see in a lot of cases when I'm looking at these C-SNP plans around the country is lower copayments at specialists, lower copayments at the hospital, maybe better give back options for those plans, as well as in a lot of cases, like for instance, diabetics, you're going to see a lower tier level or better coverage for things like insulin on these plans. So it does give your clients better benefits to be on those plans. Not only does it give your clients better benefits, but it also gives the carriers more money and higher margins. So you're making the carriers happy and you're making the clients happy by getting them on the right plan. Now, if we jump back to the article, keep coming down here, and we look at who are the carriers that are dominating this market, it's going to be UnitedHealthcare with 51% of all C-SNPs. Humana, they've got 20% of all C-SNPs, and Elevance at 12% of C-SNPs. So you've got three carriers. If you don't have them as one of the carriers that you offer, I'd be surprised because they are some of the top carriers in the country, but you need to if you want to be able to offer C-SNPs to your clients around the country or just in your local general area. And if we look at this, it does line up well, but it also points out another carrier that I think is kind of jumping into the fray. So this is from the landscape file that you can download from CMS. It lays out all of the plans all across the county or country by county, and it breaks them all down. And so these are all the non-special needs plans, the MAPD plan category. And as you can see, Humana is at the top with the most number of plans, 643. UnitedHealthcare down below at almost 500. CVS or Aetna at 460. Devoted at 218. This is Healthcare Service Corporation, which was Cigna, now HealthSpring, 184. Elevance and Centene, which is WellCare. If we come over here to the SNP side, we do have UnitedHealthcare at 340, Humana still in there, but Devoted's jumped up. We've seen a huge jump in Devoted. They've grown. They're in 999 counties across the country. They had a big emphasis on their SNP side of the market. Now, even through annual enrollment period, a lot of people don't think about SNP plans inside the annual enrollment period because they go, oh, those are what I do during the rest of the year when I need a special election period to enroll a client. Well, that is true outside of the annual enrollment period. If somebody qualifies and they have a qualifying event, then they can use a special election and you can enroll somebody in a C-SNP plan if they are not on a C-SNP plan during the rest of the year. But if you are doing your job as an agent, it is extremely important to be doing that now in looking at chronic condition special needs plans, because if you get that person on that plan, for one, it's going to be better benefits for them. It's going to give them more coverage. It's going to be better for the carrier because they're going to have higher margins, so they're going to be happier. And it's also going to be able to be better for you as the agent, that you're not going to lose that client halfway through the year because they were out at a bunco game or something with all of their friends, and they find out that their friends, insulin is half the price of what they're paying, or they've got a lower copayment when they go to the specialist. And then they find it and they go, oh, you know what? I'm going to need to talk to your agent that sold you that plan because my agent sold me the wrong plan. Now, here's something important about the enrollment in somebody in a special needs chronic condition plan. This is from Aetna, and this is how it works. Essentially, if you enroll somebody in a C-SNP plan and they're on it for that specific disease or chronic condition, let's say they're a diabetic, well, they can't change off of that diabetic special needs plan until the next annual election period, or unless they qualify for a different chronic condition, and then they're going to enroll in a chronic condition plan for that separate chronic condition. So that is if they maybe have cardiovascular disease and they want to enroll in a separate cardiovascular plan. So you're going to be locking them in for the plan for the year, not locking them in, but they're going to be on that plan for the year, just like everybody else on Medicare. And they're going to be on the right plan. They're not going to have a reason to want to make a change because you've already found the best plan for them in your area. So it's super important that we are the experts at our job. We look at all the plans that are available. Don't just simply go to the regular Medicare Advantage plans and not have to worry about special enrollment periods because it is the annual enrollment period. You can enroll them in these chronic condition plans now. Get them on the right plan. Get them those better give backs. Get them lower co-payments for their prescription drugs or going to the specialist. Even, I've seen it for lower co-payments at the hospitals. Their carriers are getting more funding, so they make the plans more attractive. Not to mention, a lot of these carriers do offer HRA payments for agents for mainly just chronic condition and dual eligible special needs plans. A lot of carriers have gone away from HRA payments for all the other enrollments. So look at all the plans available in your area. Find the best options for your clients. Get them on that plan. Make them happy as the client. Make the carrier happy because they're getting paid more. And you're going to be happy because you're not getting a charge back halfway through the year. I hope this was helpful. If you have any questions, contact information is below. You can also join our Facebook group, The Insurance Disruptors on Facebook. Subscribe. And I would love any feedback on any of the videos that I have. Would love to hear from you guys. Reach out to me. If you have any questions, don't hesitate. All right. Have a nice day and keep killing it this AEP.